Good morning and welcome to the September session of the Epilepsy Seminar Series. A couple of quick announcements as usual. Those in the room, please turn off your beepers and cellulars. And there will be a code at the end of the talk, which you can text to our CME office for CME credit. Another thing is if you're watching us on epilepsy.com and you would like to pose a question to the speaker, you can go to the other website, which live streams, which is GW Epilepsy Seminar Series. If you Google it, and there is a text box function there, you can forward your questions to the speaker. You can also forward your questions to our CME office through that box if you have any questions about CME credit. Today, I'm very delighted to introduce one of the most prominent names in the world of clinical epilepsy and epilepsy research, Dr. Aristea Galanopoulou. She is professor of neurology and neuroscience at the Albert Einstein College of Medicine in Bronx. She received her medical degree from the University of Athens and her PhD from McGill University. And then she pursued her clinical training in neurology and neurophysiology at Albert Einstein. She has done an extensive amount of research focusing on the pathophysiology, pathogenesis, and epileptogenesis, and in development in pediatric age group and epilepsy treatment, with a focus on the sex-specific role of GABA signaling in the developing brain. She has had many roles at the American Epilepsy Society and International League Against Epilepsy, including co-chairing the Translational Task Force of the International League Against Epilepsy and the Neurobiology Commission of the ILAE as well. And she received the Ambassador Award from the ILAE. She also received the Saul R. Corey Translational Medicine Award from Einstein. Dr. Galanopoulou also is a founding co-editor-in-chief of Epilepsia Open, and she has published extensively in major journals on epilepsy. Welcome to Washington.
Thank you very much, Mohammed. It's a great pleasure and honor to have the opportunity to visit your institution. I had the chance to interact with Mohammed on many occasions at the AES through meetings, and it's a unique opportunity to see your institution and your department. So thank you for the invitation. So there are a few slides that I will have to show. This is about the archived events that you can find on the website, my disclosures. And with the talk today, I will not so much talk about clinical epilepsy. I will obviously introduce the pertinence to some of the clinical epilepsy syndromes that we encounter in epilepsy, but I will talk to you a little bit about the preclinical development for new therapies for human epilepsy syndromes, some of the advances that we have had, and some of the challenges and initiatives that have been undergone recently to improve the field. So hopefully by the end of the talk, what I would hope to achieve is to present an overview of the current state of treating infants with infantile spasms. This is the syndrome that my research has been mostly focused recently. I will introduce some of the preclinical advances in the identification of therapy targets and new investigative treatments for infantile spasms and West syndrome, and present the translational initiatives that the American Epilepsy Society, in collaboration with International League Against Epilepsy and many other investigators all over the world, have done recently with a goal to accelerate and improve preclinical studies. So these are again some of the CME credit slides that will be important to show how you can claim the CME credit. So infantile spasms belongs in a category of conditions that are called epileptic encephalopathies. And with this slide, I give you the definition that was proposed in 2010 by the International League Against Epilepsy, presenting exactly the concept that epileptic encephalopathies embody the notion that the epileptic activity per se may contribute to severe cognitive and behavioral impairments above and beyond what might be expected from the underlying pathology. For example, cortical malformations or other structural lesions or metabolic, and that these can worsen over time. So this presents the notion that epilepsy per se is the bigger burden and trigger for the bad prognosis in many of those diseases. Epileptic encephalopathies can present along a continuum of severity and may occur at any age, but they are more common early in life, in childhood, and when they happen, they are obviously the impact on the quality of life and the functioning of the kid is more severe. And also they tend to manifest with pharmacoresistance, which creates a bigger burden for us in the epilepsy field to try to find better therapies for these conditions. There's numerous early life epilepsies, and with this slide I'm giving you just some of the epileptic encephalopathies according to the age group that we encounter them. And what changed recently in the epilepsy research field is that we started getting some animal models that allow us to study different questions about those syndromes, whether these have to do with etiologies, for instance, the genetic models of epilepsies with genetic etiology, or whether these have to do with the phenotype. And I will refer to some of the models of infantile spasms that we have been using to find some answers about this condition. What is infantile spasms? I'm sure that most of you know. It's considered a rare disease. However, for tertiary centers like ours, it's not uncommon at all to see regularly kids with infantile spasms, exactly for the reason that these are not easy to treat. So they need a little bit better attention and more specialized kind of treatment and management. They usually manifest during the infantile stage, typically year 1 of life, sometimes with a later onset. And they manifest with characteristic syndrome seizures that are very different to the focal or generalized seizures that we're used to in adult epilepsy. These are clusters of flexion or extension spasms that happen repetitively, then they may go away, and then they happen again. And the more dramatic finding is that they have developmental arrest or regression. Here you can see some of the characteristic EEGs that we often see in such cases, like the hypsarrhythmia. Many, although not all of the kids with spasms or West syndrome have hypsarrhythmia, and this is the chaotic, high amplitude, multifocally epileptic EEG that you see on the EEG on the top left. And during the ictus, the spasm, the signature on the EEG typically is a decremental response. So you see that there is a high amplitude EEG, and then it starts flattening for a few seconds, and then it comes back. So this is very different, but it's also more easy to recognize because these are motor seizures. The etiologies are very numerous, as I'm going to show you later on as well. The majority, or almost 60%, are due to metabolic or structural abnormalities. There is a growing percentage of kids who have genetic etiologies underlying those, but still, like almost a third of those cases, we don't know what triggers spasms, which makes it a little bit more difficult for us to treat and understand or model in animals. The prognosis is not as good. The treatments that we give and we have available are a little bit different again from the classical anti-seizure drugs that we have in adult epilepsy, and these include hormonal treatment like ACTH, glucocorticoids, vigabatrin, which is a GABA aminotransferase inhibitor, and what it does, it increases the availability of GABA in the brain, making it more active and suppressing seizures. And also other modalities can be used, like ketogenic diet, B6, valproic acid, and so on. However, the first line medications that typically we give is either hormonal or vigabatrin. The mortality is quite significant, and it depends on for how long you observe the kids. And the reports have ranged from 7 to 49% after long-term follow-up of the patients. Cessation of spasms, which is the goal of the treatment, occurs not in all of the kids. and it ranges between 29 or 62%, depending on the studies. ACTH tends to have a better efficacy, but there are cases that vigabatrin has a special indication, like the tuberous sclerosis patients for whom it is becomes the first line. And this is one of the epilepsy conditions where, by treating the patient, we try to stop spasms and stop hypsarrhythmia. So this is something that we really have to look the EEG to make a judgment. Despite treatment, there is a lot of relapses, almost in a third of the cases, and ultimately when the kids grow up, they still may have cognitive problems. So 22% in some studies were reported as having a normal or slightly subnormal cognitive outcome, defined as IQ more than 68, and this is worse in kids who have a structural etiology and better in kids who have unknown etiology. So etiology also contributes a lot in these cases. And there can be persistent epilepsy, sometimes intractable, and also neurodevelopmental problems. And this is the study that was published recently by Mittiger that shows you the breakdown of the treatment choices according to etiologies. And you see that in most of the cases, ACTH is the preferred treatment, although in TSC, in tuberous sclerosis, there is a preference for vigabatrin. And this is a very nice review by Riley Ray-Conen, who studied infantile spasms for long, and it gives you the point that despite what we have now, we really need to have better treatments. And I highlighted the efficacy of treating those kids that is by far suboptimal and not where we want to go. So there's a lot of room to improve, and also considering that some of those treatments do have side effects and we need better and safer medications, and that's why we need some basic science and translational science to help us. The advantage of doing clinical practice is that it is relatively feasible and easy to generate consortia of multiple centers to collect a lot of patients with what we consider rare diseases, and this is exactly what the PERC has done, and they have managed to come up with a lot of publications recently about the treatments, the outcome, and other features of the infantile spasms. And this is again a large experience based on 230 infants with infantile spasms that still gives you the idea that overall the responders range between 36 to 55%, depending on the first line medication. So this is again giving you the idea that we're not where we're supposed to be. There have been some older studies that gave the message that early treatment and early successful treatment of infantile spasms may indeed improve outcome in terms of the functional outcome, but this is largely based on kids with spasms due to unknown or idiopathic etiology. Prognosis is a little bit worse if you have a structural reason, and that has been an impetus in our lab to try to identify treatments that fast quickly. Because remember, when we start to implement either ACTH or vigabatrin in the hospital, it takes days for the patient to respond, which is not sufficient. So what we try to achieve, to aim for in our lab, is to try to find treatments that may act rapidly within hours so that we can accelerate the response rate. So a few years back, there was a workshop on animal models, and sometimes these workshops are very useful because it creates a conscience in the research field that something needs to be prioritized a little bit higher in the research. So what they stressed is the importance to generate pediatric animal models for pediatric epilepsies. And they came up with a lot of criteria for the desired perfect model of infantile spasms that you can see here, including that the model should have unprovoked spasms or myoclonic seizures early in postnatal development, EEG correlates of seizure events like ictal and decremental responses, hypsarrhythmia, abnormal interictal EEGs, response to clinically relevant treatments like ACTH and vigabatrin, behavioral and cognitive sequelae. So that workshop in many of our the opinions of the investigators, has been extremely successful, mainly for the reason that that was an impetus that led to the generation of many animal models after that. And from the situation that we didn't have any model of spasms, now we're talking, as I'm going to show you, about a multitude of models that model different aspects of the disease. However, as clinicians, when I look at this set of criteria, you can easily recognize that if a model is responsive to clinically relevant treatments, ACTH and vigabatrin, it would model clinically responsive spasms. But how would a finding in this model relate to a patient that does not respond? How can we model refractoriness? The other limitation in the basic science is that if I have to generate a model of hypsarrhythmia in a neonatal rat or neonatal mouse, it's really not easy, because the size of the skull and of the head is very, very small to allow multiple electrodes to be placed to document chaotic, multifocally epileptic EEG, which is not easy without damaging the brain. So we really have to look at those criteria with a critical eye, take the best out of that, but also when we do an animal model, we really have to recognize not only the limitations, but also what the model offers, and that's important for the field to go forward. So when you try to make a model in the lab, you start with the etiology, and this is not the complete set of genetic etiologies. This is up to date, up to 2015. There's a slew of structural metabolic etiologies that it makes it difficult to say I'm going to pick this gene or this gene mutation and I'm going to make a treatment that is applicable across the spectrum of kids with infantile spasms. It may not be the case, it may be successful, but there is a high risk for that. And if you try to think about networks, these are examples of imaging studies from kids with infantile spasms that can present either a brain that you cannot find much of an abnormality or a brain that you really have a hard time finding a brain there. I mean, the cases of hydranencephaly that were described for the longest in kids with infantile spasms is a classical example that we don't necessarily deal with a limbic epilepsy. We deal with a little bit more different case scenario here. So it's very challenging, and that's why some of the models that exist right now have aimed for phenotype. What is the model that generates spasms that have epileptic correlate? So this is what we have, and we do have acute models that reproduce epileptic spasms after you do something to the animal, either typically an injection of a chemoconvulsant, like the NMDA receptor model, that NMDA model that was the first one that Ambrostotonus was described. Many variations of the NMDA model introducing prenatal or perinatal insults, like the prenatal betamethasone, prenatal stress, perinatal adrenalectomy, followed by postnatal NMDA. And we have the Down syndrome mouse model in which gamma butyrolactone triggers epileptic spasms, which have a little bit, they're not as age specific, but they do show the phenotype. And the models, the acute models, are useful to let us know about what generates the seizure per se, but they're not very helpful so far in terms of telling us what is important for the chronic phenotype, for epileptogenesis and the long-term outcomes. We do have chronic models which manifest an evolution of a phenotype. The tetrodotoxin model, this is a model that is introduced by giving this substance that inhibits sodium channels chronically, and then the rats develop spasms that last throughout the life. And that has been used as a model of hypsarrhythmia, and mainly for the reason that EEG recordings in this model have been done in adulthood or in more developed ages of life that allowed more electrodes to be placed, something that is not feasible in very young ages of a rat's development. We do have a few genetic models, the ARX, Aristea S linked homeobox gene, the conditional knockout model, and the ARX knock-in plus 10 model, which I'll briefly introduce later on, that try to mimic an etiology that sometimes we find in humans, ARX mutations. And they also develop a chronic phenotype of epilepsy and sometimes with neurodevelopmental and behavioral disorders. And the ARX model I have to mention is that when the first mutation was identified in humans, they noticed the relevance of what they called interneuronopathy to the pathology of some epileptic encephalopathies like spasms, meaning the abnormal migration of interneurons in the cortex that probably was thought to be contributing to the epilepsy. And the multiple hit rat model, which is the one that we developed in our lab, is a model of structural etiology, and I will describe later on. At the same time, over the last few years, there have been other models that have been proposed, and we'll keep learning a little bit more about those, and these are the chronic early life stress, the adenomatous polyposis colon gene knockout model. Acute recordings have demonstrated some interesting patterns in a tuberous sclerosis one mouse model, and it's worth mentioning that from the in vivo monitoring of mouse models of tuberous sclerosis, there haven't been any reports of epileptic spasms, unlike the clinical situation where tuberous sclerosis is one of the common etiologies for infantile spasms. So the interest in this model is that it started bringing up some interesting electrographic patterns that these investigators found in the TSC1 mouse model that they developed. And also there is an acute model of prenatal MAM, postnatal NMDA. So what they try to introduce is a model of dysplasias and spasms, which is, however, acute. For the clinicians, it's the main purpose for this slide is to give you the message that it is very difficult to create an equivalency criterion between the developmental stages in rats and humans. Classically, we consider a P10 rat equivalent to a full-term newborn baby, and therefore the first week of life is a precocious preterm baby, which is immature, and a 2-month-old rat or mouse is an adult rat. However, as we read the literature, it is very difficult to make an extrapolation for anything that we study, and it is very important to look at every process that we study differently, because there's different developmental trajectories for the various processes that we study, as the table on the top right corner indicates. Different processes develop in their own tempos, and we really have to be very cautious, and particularly for the infantile spasms model, although P10 we consider full-term newborn baby, the second week of life is when the pups, the rats, start to ambulate and they become movable, which is not like the infantile stage in humans. So it's very difficult to make such strict criteria, and that's one of the reasons why in our studies we went a little bit earlier and we induced the model in the first week of life, because that's when the ambulation or the development of the motor system has not been developed yet, similar as to the human infant babies. So this is a gross diagram of what the multiple hit model of infantile spasms models. We also call it DLP because of the compounds that we use to induce it. It is induced in Sprague-Dawley rats. We have done it in mice, but the studies that I will give you is basically on rats. And at postnatal day 3, we give intracranially on the right side doxorubicin and lipopolysaccharide. And the idea was that the intent was to generate a model of structural lesion. So the combination of these two drugs that Maurice Candleberry gave many years ago was intended to generate a lesion in the brain. And you see that in the histology on the panel A, on the top left, that you see that the right hemisphere is atrophic. And also at postnatal day 5, we give chlorophenylalanine, which is a depleter of serotonin. The two drugs at P3 are sufficient to induce spasms, and these are classically the triggers of the phenotype. The EEGs demonstrate bilaterally epileptic interictal discharges, and when we do have the flexion or extension spasms that these rats manifest between P4 and P13, we have seen decremental responses associated with most of them. So the phenotype is a period of life between P4 and P13 that we have those cluster of spasms. There is evolution and emergence of other types of seizures after that. And by long-term monitoring in adulthood, we see motor seizures in almost 2/3 of the rats when they develop in adulthood. But we also have documented learning deficits, neurodevelopmental deficits, and consistent with a bad developmental outcome. And here you see some of the milestones of development. The green lines and bars typically are the DLP pups, that's the pups with spasms, and the black lines and bars are the controls. And you see that the pups with spasms show a little bit of regression, although they started developing normally. After the induction, they develop a kind of regression. And when we test them in the social chamber, which is a test of sociability, they do not care to interact with other rats, familiar or strangers, so it's a kind of deficit that they have. And in the Barnes maze, when we tested them for learning and memory, they have pronounced deficits. You see the black bars, that there is a gradual improvement in the performance. The bars become smaller and smaller with repetitive trials. The green bars just stay as they are, so it's a very significant deficit that partly can be due because of the structural lesion, but as I'm going to show you later on, it's not only that, because we can improve it with some treatments. So we used the model of multiple hit model of spasms in our lab mainly to develop treatments for infantile spasms, and the advantage that we had was that there was a chronic phenotype, that we could have different endpoints, not only in terms of epilepsy but also in terms of development. And to do that, we realized that this is not something that can be done by a single lab with a single expertise. So we assembled a group, a consortium to help us in that effort. So we do have in our lab the phenotyping, the preclinical screening for the epilepsy and behavioral. We do have a statistician who adds basically to the rigorous assessment of the blinded data collection that we do. We have a collaboration with Minnesota, with Lisa Coles and Jean Cloyd for pharmacokinetics, pharmacodynamic modeling. And we created a proposal to have a stepwise pattern of screening for compounds, starting from single injections and then progressing into repetitive injections and looking initially at seizures, at spasms, and down the road also at behavioral and other types of seizures. And this is not up-to-date slide, but this is some of the earliest publications that give you an idea about what is the pharmacosensitivity of the model. It is ACTH resistant. We have not found an effect with ACTH on spasms. With vigabatrin, we did find a partial effect, so they do respond to spasms, but when we tried vigabatrin, it was very challenging because there was mortality, because the rats were sedated, they were not feeding. So although we did have some partial efficacy and transient, it was not the best effect. I will talk to you later about some of the newer compounds that I have in the slide. And we also tested phenytoin for the reason that phenytoin is not supposed to work in kids with spasms, and indeed it does not work in our model. So based on these drugs, we consider that as a model of drug-resistant infantile spasms, which is not unexpected because it's a structural etiology model, and we have used it to look at the effects of other drugs. So this is an interesting study with Carisbamed. Some of you may remember this drug because there was a lot of talk some time ago about the excellent effects in the preclinical studies in many different types of epilepsies, not just anti-seizure but also anti-epileptogenic effects. It came into the clinical trial testing initially with PROMIS, and then there was a multi-center international study, big study, that was done in 2 cohorts, 2 international cohorts, and based on that efficacy, that in one cohort it showed efficacy, but in another it failed, it was not it did not proceed for further development. The reason that I'm saying to you is that for us who do preclinical studies and animal research, we're always very commonly faced with a critique that sometimes what we find in the preclinical field does not always translate into a clinical field. But that was a very nice example that I always like to quote, because that was a very nicely done study with a very promising drug that many of us still believe that it would be worth giving another trial. But you have different effects in 2 different clinical cohorts of patients according to the same clinical design. And there's a lot of that we need to know about what consists, what makes a failure, true failure, and when are the other factors that we can supervene, for example, drug-to-drug interactions or other unknown things that may confound an effect. So we really have to have a very open eye when we look at studies like that and try to discern what is true success, what is true failure, and how to compare and validate findings from one study to the other, whether preclinical or clinical or within the same research field arena. So back in the early 2000s, we decided to study CarismaMed in our model. And the interesting feature about CarismaMed, when you compare with the green line that is a vehicle-treated group, we always do dose-response treatments, vehicle versus treated, and these are all blinded, randomized studies. We saw that the CarismaMed, at least a couple of the doses of CarismaMed had a very rapid effect in suppressing spasms, which is a kind of unique because we don't see that in the clinical field with ACTH or vigabatrin, and this is a single injection of the drug. And we saw that in the phenotype, the behavioral epileptic spasms, but also in the video EEG studies that we did, that it showed a reduction, significant suppression of electroclinical spasms in the model. Obviously, the drug has not gone further, but it gives an idea that there are still compounds and interventions that could help us achieve some better control of the spasms. I'll talk to you a little bit more about CPP-1105, and again, these are investigative usages of the drugs. I'm not presenting any clinical trials. I'll talk only about a case report that is interesting. So we have to take those findings for what they represent. CPP-115 is a high affinity vigabatrin analog that the idea was that given that vigabatrin has retinal toxicity associated, the investigators thought that a significant, a possible reason for the retinal toxicity could be drug-related toxicity. So they thought that by giving a higher affinity analog, it may allow them to reduce the dose of the drug, achieve efficacy, and then also reduce the adverse effects of the drug. So that was the concept between the science of trying to make a high affinity vigabatrin analogs. And indeed, in rodent studies that they did for retinal toxicity, they did see that the new drug, which has 100 times more affinity to GABA aminotransferase than vigabatrin, had significantly less retinal toxicity compared to vigabatrin if you compare the blue bars compared to the red bars. And that was a very promising finding. So when they asked us to test the compound in our lab, and we only received the chemical compound from the company, this is not sponsored by a company in any other way, and we do not have any commercial interest for this compound. We did find that the tolerability and the efficacy of this analog was actually much better compared to vigabatrin. So we did notice a reduction in the spasms with doses of the CPP-115, which were 100 times lower compared to vigabatrin. We confirmed that with video EEG studies in P6, P7 rats, and also interestingly the survival and tolerability of the drug was much better than vigabatrin. So that gave a sense of optimism that there may be some new compounds that may help this population of kids if confirmed by clinical studies with a safer profile. And it was very encouraging that this is a report by Devinsky's group, that they tested this compound in a single clinical case of a kid with infantile spasms. And you can see here that the kid started having, initially had a lot of spasms, as you see in the first two columns when he was on vigabatrin. But then when they switched from vigabatrin to CPP-115, which is the red line, spasms declined and tolerability of the drug improved. So this has a lot of similarities with some of the findings that we had in the model. I grant you it's not perfect, but in a desperate case that somebody has a lot of epileptic seizures and sequelae from them, it is something to be appreciated. But it needs further validation by more observations, clinical observations, and there has been a phase 1 trial that has been ongoing. And there are a few other cases in humans that they have been reported that patients have been given CPP-115, and the idea behind this study was to use MRS to monitor the efficacy of the drug in increasing GABA in the brain as a biomarker of the effect of the drug. So hopefully in the future we may know more about these analogs. Another interest in our lab was the neuroinflammation for many reasons, because there's a lot of interest in how neuroinflammation is implicated in epilepsy. Specifically for infantile spasms, neuroinflammatory pathways are important because they have been implicated in a number of pathologies. And these can be infectious causes of infantile spasms like meningitis, encephalitis, tuberous sclerosis. A significant number of kids with mutations in TSC can manifest spasms, and I refer to Elizabeth Till's clinical trials that give a significant percentage of kids with TSC have spasms. Even in cortical dysplasias or malformations, Pete Crino has shown that there is dysregulation of downstream targets of mTOR pathway. And there's also reports of autoimmune etiologies of spasms, and also inflammation can be implicated in several other acquired etiologies of spasms like hypoxic ischemic encephalopathy and so on. And beyond that, some of the treatments that we currently use, like ACTH or steroids, or even vigabatrin ketogenic diet, they do have the ability to modulate inflammatory pathways. So we looked to see whether some of those can be important for the treatment of spasms, and we started with the mTOR inhibitor rapamycin, which was available, and we looked to see whether that could have a relevance for the model that we have, the multiple hit. And indeed, what we noticed, as you see in the histology photographs, there is an upregulation of the phosphorylated form of S6 ribosomal protein, suggesting overactivation of the mTOR pathway. And therefore, we tested whether rapamycin may have an effect, and we went through different treatment protocols, doses of rapamycin in terms of not only dose, but also duration of exposure. And as you know, rapamycin is not a benign drug. It can have side effects like weight growth. So at the end of the day, and after many years of testing, we came up with a refined protocol where we give a 3-day high-dose pulse rapamycin to rats after they start having spasms. So these are on symptomatic pups with spasms. So we induce it at P3, and between P4 and P6 we expose the rats to rapamycin. And what we saw, as you can see from the red line on the graph on the bottom left, you see a suppression of spasms after the pulse treatment. And when we looked at the Barnes maze that you see on the graph, the middle graph on the right side of the slide, the green line, which is familiar to you, shows no learning, but the red line shows partial improvement compared to how the PAPs usually do, but it's still not same as the gray line, which are the controls. So it does show some improvement and disease modification between P16 to P19, which is far beyond the period of exposure to the drug, and the drug has washed out already. And you see sustained benefit in learning on those rats, suggesting that by treating epilepsy or the syndrome at the asymptomatic state can help improve the long-term course of the disease. But what another feature that is important to remember in this slide is that if you compare the purple line, which is just above the gray, and the gray line, that's the controls, are the gray, and the purple are the naive controls treated with rapamycin. The naive controls treated with rapamycin, they don't do well, which is important to remember because drugs are meant for a disease. They're not meant for normal, healthy subjects. And everything, most of the things in the human brain and biology is a balance. So if you tip it over or if you tip it under that balance range, then you may have side effects. And that's one of the reasons why in the approaches that we try to identify drugs, we prefer to treat rats that have already manifested epilepsy, not pre-treat, not before the onset of or induction of epilepsy. And that's something to remember. And in terms of the tolerability, although we did see some deceleration of the weight growth during the exposure, the rats recovered and they regained the normal weight growth after that. So that's a kind of promising development that introduces the concept that some of the interventions that we may have in, at Stoke for further testing and validation can actually have the potential to alter the disease course. And we have done tons of other drugs. This is a more updated table, and I like to give the graph on the left because a little bit it reminds you of the high throughput analysis, omics or data that are fast to get and easy to show with complicated graphs and heat maps and all that. But for us who do in vivo drug testing in chronic models of epilepsies, we all know how laborious this is, and our postdocs can attest to that. So that basically speaks for the tremendous effort of the group that has worked in my lab to continue doing those studies with the hope of finding something better. But the advantage of having a systematic way of comparing treatments is also presenting another opportunity to compare efficacies and tolerabilities between drugs that are tested at the same testing. So we use the kind of same method of single versus repetitive, and we do have standardized endpoints that we look, and that allows us to compare efficacies across different treatments, which can be valuable when down the road we can prioritize which ones to proceed for further development. A few years back, there was an initiative by Cure, the Infantile Spasms Initiative, that was one of the first in the field that felt that to address globally and systematically a problem, you may need to have a team science approach. So what they did is they funded a few preclinical and clinical investigators that worked on infantile spasms to do different types of research. And although we proposed our own proposal, at the end of the day, for several years, we were asked to go to a team science roundtable, discuss our findings, revise our endpoints, find ways of collaborating, and ways of checking one's work to another lab's work. So that was a very unique experience that we had. And I think this is something that is worth expanding in the future. But I'm just going to mention one example of the experience that I had in this initiative, because it is important as we look at animal models. I spoke earlier about the ARX mutation, and this is a mutation, a gene that has been found in humans with infantile spasms and many other epileptic encephalopathies like Ohtahara, idiopathic infantile epileptic dyskinetic encephalopathy, and so on. And it is a transcriptional factor that is important to control the ventral telencephalon morphogenesis, migration of GABAergic neuronal progenitors, and the early commitment of cholinergic neurons. So in a sense, it tells interneurons to go where they're supposed to go, and it helps them acquire the role that they're supposed to play in controlling brain activity. In the animal model world, there is a few models of ARX defects. Two of them manifest spasms, at least as the investigators reported, and this is the conditional knockout and the knock-in mutation mouse model by Jeff Nobles' group. And in the model from the ARX knock-in mouse, there is an interesting phenotype that I have here from the publication that the group produced several years ago, that they do have spasms, they do have other epileptic seizures down the road that are different, like generalized seizures, they have behavioral arrests, and they do have an interesting pathology which they call interneuronopathy, which I mentioned earlier that this was a term that was introduced by Cato and colleagues for the ARX mutations in humans. So what that means is that they have less interneurons in the cortex and some of the basal ganglia, and this was a kind of cell type specific deficit in this model. And also the model manifests behavioral abnormalities like low anxiety, impaired associative learning, and abnormal social interactions. So it gave a very nice platform and model to test not only mechanisms but also treatments. And a very interesting study came across by Olivetti et al., who proposed that neonatal estradiol in this model of ARX knock-in mouse does indeed prevent epilepsy in the mouse model. And so when they gave it at P3 to P10, it prevented the expression of spasms and other seizures, but it did not prevent that if estradiol was given at a later time point. So it kind of reminded us the value of critical or sensitive periods during development that may be relevant as we think about administering drugs and treatments in humans. This is very interesting study, and the model also presents an opportunity because it's very easy to identify patients with that mutation. You can do an early genetic screening, and if there is an effective treatment, you can administer.
Both males and females survive in the ARX model?
So these are male. This was done in males. So the neonatal estradiol, exactly, which is another point, was given in the male pups. And also they showed a restoration of the interneuronal deficit in the mouse model, consistent of disease modification. We and others have tried to do that in acquired models of spasms, and we did not find the effect, which I'm not mentioning that to discard the value of the ARX knock-in, because but the message that I want to give you is we have to basically be able to interpret findings in the context that they are presented. Because although we do have interneuronopathy in our model, it is of different etiology, it may not respond to the same treatment, the lack of efficacy may not necessarily suggest, that invalidate a finding. But the other important message that I would like to put forward is that genetic epilepsies present a unique opportunity for treatment, and early treatment, and sometimes preventative treatment, just like what Nobles' group did. However, if I tell you that you have to give neonatal estradiol in a baby boy with ARX mutation before the spasms begin, and I don't know what the P3 to P10 in a rat or a mouse correlates or is equivalent to in a human, it's a big risk. So as a community, we really need to develop better tools to help us validate and most importantly translate our findings from the preclinical field to the clinical in order to make the better use of what we discover. And that's something that probably would be worth become a priority in the field, just to allow us to get tools to translate preclinical into clinical studies. And that brings me to an international initiative that was done recently. So back in 2010, there was a workshop by an NTS on anti-epileptogenesis, and there's a lot of discussions that started in parallel in many different areas of the world about how can we improve and accelerate preclinical epilepsy therapy discovery. And that became an internal discussion at the International League Against Epilepsy, by the Working Group on Recommendations for Preclinical Epilepsy Drug Discovery, by Simonato and O'Brien, the co-chairs, and also at the American Epilepsy Society by the Basic Science Committee by Paul Buckmaster and Kevin Staley. And at the end of the day, that created a unique opportunity for collaboration between these two committees. And there was a concerted effort and a lot of discussion that led to a special report highlighting the challenges of preclinical epilepsy therapy development. What is the advantage, what is the disadvantage, and what needs to be done, and what we have to be cautious. So that was like the flag of the effort that led into an international workshop on translational epilepsy research in London in 2012 that assembled almost 50 international investigators. And we produced a number of publications giving us our expert opinion about different things that we could do better when we think about therapy development in epilepsy. So this effort has been ongoing, and that led to a joint translational task force by ILE and AES that I had the honor of co-chairing with Jackie French, Terry O'Brien, and Simonato. And in the previous cycle, the priorities that were set by this group was to, number one, harmonize the way that we perform and interpret the rodent video EEG studies or electrophysiological studies, because unlike what we in the clinical epilepsies learn how to interpret a human EEG, there is no such textbook or standards in the preclinical field. So this is the ultimate goal of the effort, just to try to utilize systematic reviews to address different important questions. And this is the first study that they chose was the identification and characterization of outcome measures reported in animal models of epilepsy. Task 3 did a kind of a unique approach by trying to generate preclinical common data elements, and I will talk to you a little bit about those because this is an important to know development. And task 4, the goal was to think about improving the infrastructure to develop multi-center preclinical trials, which have not been happening so far. The important experience from this effort was that it started with a group of 10, a committee of 10. We grew to be a group of volunteers, of 163 volunteers all over the world. And that speaks for the importance of the task, but also that this is something that is deep to the heart of many people in epilepsy research. And there's a number of publications that have and are coming up. This is some examples from the rodent video EEGs from Epilepsia and Epilepsia Open. And there is a special issue in Epilepsia Open that will introduce the first common data elements for epilepsy research. What these are is basically, it's an attempt to find a common language when we log and report animal studies the way that we do them. The ultimate goal would be, number one, to allow people to compare findings from one lab to the other, but also down the road to allow investigators, if they want, to put their data in big databases and allow meta-analysis and mining of those big data for better discoveries and more powerful discoveries down the road. And this is what they look like. The table, the Excel on the top is mostly for data analysis. That's the data element and the dictionary. And the logo on the bottom is a case report form. And with the new cycle of the task force, we try to make them more user-friendly for the investigators, like generate digital compounds. And I'll conclude with another experience that I had with the EpiBios 4Rx, which I don't know how many of you are familiar, but this is the first multi-center preclinical trial on disease modification in an epilepsy model, the post-traumatic epilepsy model. So what we try to do here is generate a center without walls that has preclinical and clinical components and projects that try to develop, identify biomarkers of epileptogenesis, new treatments with disease modification, but also identify clinical biomarkers that will allow us down the road to compare and translate our findings. And another interesting feature of the Center Without Walls is that there is also a public engagement core that introduces the input from the public, from the community, that is important as we think about trial design. So this is just to show you that we started with some of the advances in candidate treatments, and the project 2 that I'm leading is exactly the first preclinical multicenter study that we try to test some of the treatments as to their ability to prevent epilepsy. And why did we choose the preclinical multicenter study? This is a table that gives you the extent of the problem. If you try to develop anti-epileptogenesis and specifically prevent epilepsy in a population and reduce, for example, the epilepsy risk from 30% to 15%, you will need 122 subjects per group to have a power of 80%. There is no lab that can do it on their own. So by creating a multi-center study, it allows you to add strength and power to the studies that you do, plus it allows you to generate a kind of internal control. It is not a finding based on one single lab, but is a finding that is across labs. And this is, these are the colleagues and collaborators that work with me in the project too. As you can see, it's not just USA, but it's also Finland and Australia. So, and there's multiple centers throughout the world. So we look forward to the outcome of this. And to conclude, I hope that I went through some basics about the development of new models for pediatric epilepsies, and I gave you an idea as to how they can open new avenues for syndrome and age-specific pediatric therapy development. We're not just at the era of extrapolating drugs from the adults to pediatric, but we can use special tools to develop treatments just for kids. I gave you some of our experience with the multiple hit model of West, introduced some of the translational initiatives that we have been promoting in the international epilepsy research, and the concept of multi-center preclinical trial. And I would like to conclude with the acknowledging the multiple people that have worked with me in these experiments, the funding agencies that have supported the work, and I think there are some slides that I should introduce about the CME credits, how to claim them, and that's the end. And thank you very much for your attention.
Thank you so much. I have a couple of questions, and then I'll give the microphone to the audience in the room. First question is, are you aware of any studies on cannabidiol in infantile spasms?
There should be. That's my answer. As you know, there's a lot in the preclinical field. There's a lot of restrictions in terms of the usage of opioids, of cannabis-related projects. So I don't think there is anything published in the preclinical field, but I strongly feel that things should improve in allowing investigators to get a better access to drugs that need to be studied.
A couple of questions all related to the DLP, to the multiple hit. First, in the studies of treatment, such as rapamycin or CPP-115, how were seizures quantified, and in what time blocks?
So in the early ages of life, obviously you cannot do continuous video EEG recordings because you have to return the pups back to the mother. So the protocol that we have for the monitoring is we separate intermittently the pups from the mother so that it can allow us to monitor both behavior and video EEG when we do that. So it is at least 2 sessions of 2 hours each every day, and in some of the single injection experiments that we have planned, we also include a more prolonged period, like 6 hours a day, meaning a baseline and then injection of the drug and then monitoring over 5 hours, which the pups tolerate well, and it allows us to give some kind of time response element in the endpoints.
These animals continue to have seizures when they become adults. Are the seizures continuous from infancy on, or is there a latency phase before they re-emerge?
That's a good question. We have seen other types of seizures as early as P9, postnatal day 9. However, you cannot do a long-term monitoring from P9, let's say, up to adulthood because the brain grows. So the monitoring in adulthood that we did is we implanted at 2 months of age with electrodes, and we did months of recordings, 4 to 5 months of recordings to document that epilepsy. So whether the seizures continue from P9 through adulthood and they evolve, or whether they remit and then they come back, I don't know yet. But we do know that in adulthood we do have motor seizures in 2/3 of the rats.
Any words about the pathology in DLP?
So we have published the pathology at different stages of development, both around P5 or P6 and around P20. So there is a lesion that is cortical and subcortical, mostly at the right hemisphere, and I showed you a picture in the slide. There is an element of progression of the lesion, which is not unusual even with other models of chronic epilepsy, because obviously the longer you have epilepsy, the more progressive lesion you have. But yeah.
And last question here. Most of the therapy studies you showed that the infantile spasms recur after a certain period. Any search for a truly anti-epileptic treatment instead of merely anti-seizure treatment in this model?
We have, and we are currently writing it up for publication. So there's some promising, new developments that may happen. So what we try to do basically is to treat very early during the acute phase of spasms, and then look for anti-epileptogenesis in adulthood. So that this is something that's
great news. Yeah. Thank you. Any questions?
So when you test all those new compounds on the 2-hit model, like with new compounds, and I noticed like all those the spasms had a significant reduction, maybe in 2 hours, 3 hours, then kind of wears off. Is that because of just this new compounds, the half-life or something? It's just shorter than I saw most others, I guess.
I'm sorry, you're referring to the single injections?
I guess the question is so those only last for a few hours, 3 hours or something. Yeah. Is that because of the pharmacokinetic or something?
Yeah, so that's exactly why we introduced the PK studies. So in the drugs, the drugs when we give them intraperitoneally, rapamycin has a long half-life, but most of the other drugs that we have tested, they have short half-lives. And that's why we expect to see the effect over a few hours. So the way that we approach it, we see first the biological effect, when do we see the effect on spasms, and then we try to correlate with the pharmacokinetics of the drug before thinking about repetitive administration. Because sometimes, often in the drugs that we use in the lab, the half-life is quite in the range of hours. So that's a kind of limitation. Great, thank you very much.